2.0. Speriamo bene. Welcome. I'm very glad to welcome all the participants of Bocconi community and all the people connected coming from CIVICA partner university from many countries, in France, in Germany, in Sweden, in Hungary, in Romania, and the United Kingdom. So it's really, really a great honor. This is the second event of the Tours of Europe series, which has the purpose to disseminate the outcome of impactful research in the social sciences, focusing on 4 major areas that are, in a certain sense, the core of the activity for CIVICA. The 4 areas are democracy in 21st century, societies in transition and crisis of Earth, Europe revisited, and data-driven technologies for social sciences. Obviously, the today event is centered around data and their role in the battle against the COVID-19 pandemic. And we will discuss this very fascinating topic with the great colleagues and friends from Bocconi University, from Central European University, and European University Institute. I would like to thank all the speakers, and especially I would like to thank Alessia Melegaro for having, in a certain sense, conceived and designed this important event. Before leaving the floor to Professor Francesco Billari, who will be the chairman of this event, let me spend a couple of words related to the CIVIC Alliance, not only for my role as a Dean of International Affairs, but also because I'm a very CIVICA enthusiastic and a very supporter of CIVICA and the project of European University. I would like to remember that the CIVICA is the European University of Social Sciences and is a part of European universities, which is the flagship initiative launched by the European Commission a couple of years ago to build and to integrate the European education area and the European research area. So it's really a big challenge, not only for university, but for Europe in itself. As partners of this alliance, we work together for the benefit of all our stakeholders, students, early stage researchers, faculty, staff, involving them in win-win interactions that not only shares and build upon already existing best practices, but produce innovative corporate cooperative ventures in education and research. I have to say that the purpose of CIVIC and European University is to be not only the sum of the part, but to be a multiplier. So a coalition of university willing to raise the bar and to produce something different with a great impact for the stakeholders themselves, but for the society and for Europe as a whole. A few months ago, Bocconi had the privilege of hosting the president of the European Commission, Ursula von der Leyen, as the keynote speaker in the academic year open ceremony. She was so kind to mention also CIVIC in her speech as an example of cooperation beyond borders. And it's a great pleasure to remember this big event. And this is exactly what CIVICA aims to be, an alliance that, going beyond borders, values the power of science, the richness of diversity, the understanding of inclusion, the freshness of youth, and the power of science. Also, on behalf of President Mario Monti and Rector Gianmario Verona, I'm very proud to virtually welcome all of you to Bocconi. I'm quite sure you will find tonight's discussion very stimulating. And I would like also to stress that I understood President Monti probably is around, and is a great pleasure to welcome in the audience Professor Monti. And now it's a great pleasure to give the mic and to give the lead to Professor Francesco Billari, Dean for Faculty at Bocconi. And so I really hope it will be a great event, and thank you very much, Francesco, and thank you very much to all the speakers.
Thank you, Stefano. Thank you, Professor Caselli. It's a privilege and an honor to chair this event with a fantastic lineup of speakers. We are talking about the pandemic and the use of data and the analysis of data and data modeling in the fight against the pandemic. We are doing that from a perspective of social science universities or our Alliance of Social Science Universities, the COVID pandemic made clear two things. The first thing is that we could basically use data to fight in a crucial way this pandemic. And this data needed some guidance in terms of how to collect them and how to model them. The second bit is that we used social sciences together with other disciplinary perspectives to guide our response to the pandemic. So social science is crucial in answering the pandemic and also in kind of analyzing the data we have to use in this response. The three speakers bring different perspectives towards this approach, and it's very important that we use this different perspective to give a general idea of how social sciences use data, generate data, deploy data in order to support this response to the pandemic. So let me call in the first speaker. The first speaker, I'm proud, is my colleague Alessia Melegaro. So Professor Melegaro is Associate Professor of Demography and Social Statistics at Bocconi University, where she's the director of the specially established Bocconi COVID Crisis Lab. She has been awarded 2 grants from the European Research Council for her research on fighting epidemics. And in particular, she's starting a new one where she's tackling the issue also related to vaccine responses and other kind of responses to the pandemic. The floor is yours, Alessia.
Thank you very much, Francesco. So it's a pleasure to be here, and I'm quite excited actually about this CIVICA event. So I'm going to talk about mathematical models to understand SARS-CoV-2 transmission. So mathematical models have been extensively used over the past year to better understand the characteristic of the infection, as well as to produce scenarios on what would have happened under certain conditions of uncertainty, being these lighter or more stringent interventions. So this framework of analysis has a long-standing history, in the sense that the model being used here were originally developed to study in demography the evolution of human populations and the interaction between different animal species. So one of the simplest form of compartmental model is what is called the SIR model, whereby we have categorized the population into 3 groups, which are epidemiologically relevant. And here we study the movements of the population across these groups. These movements are regulated through some parameters, which sometimes are coming from the literature, from the data, primary data collection. Some other times, this model needs to be calibrated on the data. In the case of a new or relatively new infection, such as the one that we have seen hitting our populations in the past year, the available information, especially at the beginning, is of course very limited, and considerable efforts have to be put in place in order to understand and characterize the infection that we have in place. So connected with this modeling framework, there are some ingredients which I believe are particularly important and need to be taken into consideration when designing and developing this kind of modeling. The first ingredient is the natural history of the infection, which embeds all the information about the relevant timings of the infections, such as the incubation period and the infectiousness period, or the transmissibility of the infection, which we have heard quite a lot about in the past year, the famous R0, or basic reproductive number. The second component is the background demographic profile of the population we're studying. And this relates to the age distribution of the population and the social structures on which the infection is actually spreading. The third component is to do with human behaviors, how people are interacting with each other, and how individuals are complying or not complying to the measures that are being put in place and that are kind of constraining our possibility of coming into contact with other individuals in our populations. Let's think about the isolation, distance-based measures, face mask use, and so on. And the fourth component, very important today in our global society, is the mobility, which provides the links between close or more distant populations and community. So, with respect to the first ingredient, so the natural history of the infection, when the infection first hit Italy, this was the 20th of February, a little bit more than a year ago, and the knowledge about the virus was really limited. And equally limited was the availability of the data we had at hand. However, through intense contact tracing of the new cases that were actually occurring in the first week of the pandemic, an interesting pattern emerged at the regional level in Lombardy, where it all started, like in the European context. And regional and national authorities understood that the infection had already reached several municipalities. And you can see this in this map below. Through the analysis of the initial part of the epidemic curve, initial estimates of the basic reproductive number, which is the number of secondary infection in a totally susceptible population, which is what we were a year ago, we estimated this number for the different provinces in which the infection had occurred. And this showed us the very high potential of this infection, as this number was well above 1, which is the recognized threshold to have an epidemic spread into a population. And we see from this figure that we have values as high as 3 and 4 in several of these municipalities. Through the analysis of the initial part of the epidemic curve, initial estimates also of the serial interval were actually positive. The serial produced. The serial interval is actually the number of days between the first infection and the secondary infection that is produced. And this was really, really important, as it allowed us to understand what was the pace at which the infection was actually going in our population. Similarly, it was possible to estimate the proportion of symptomatic and critical cases and the mortality rate in the different age groups of the population. And this analysis highlighted how much more severe the infection was among the elderly groups, and how much it was much more kind of even the case fatality ratio, the infection fatality rate was much higher in these groups. So the first model that was developed for the regional context was a simple SIR model, similar to the one I described before. And this was parameterized also using the available information about social interaction, what we call social mixing pattern, that is represented by this matrix here in the slides, which are basically telling us how individuals from different age groups are mixing between each other in a specific time point. I'm not going to go into the details about this because our colleague and friend Márton Karsai will talk about this in detail a little bit more later. So the model that was developed highlighted that the infection potential was actually massive, and without control measure in place, the number of critical cases requiring intensive care unit admissions was very, very high, especially in some age group. And this was well above the regional capacity at the hospital level. This model was very important for local policymakers, as it generated the necessary understanding that the situation was really dramatic and it needed intervention and restrictive measure straight away. A similar modeling framework was then developed and used to evaluate in a totally different context in Ethiopia the strict measures that were put in place at the very start of the pandemic. And here we used a similar social mixing pattern, but of course very, very much grounded on the social context that characterized this country, in order to understand how the transmission pattern was actually occurring in the different type of setting within the community there. The model here was able to estimate the number of positive, asymptomatic, and critical cases that were averted thanks to school closure. And the model was assuming, as I said, the demographic condition and social interaction that were very much realistic. And you can see from the graph on the right, the fact that actually a number of cases avoided in the kind of school age was really low. And this is because of the characteristic of the infections, the fact that symptomatic and severe cases in those age groups are much less frequent. So optimal... Sorry. Okay, so here we took the, we are assessing in, this is a further development of the work, in the sense that here we are assessing at a global scale the impact of demography and social mixing pattern on the evolution of the pandemic in very different geographical contexts. Here I'm just showing you the Italian and the Kenyan context just as an example, and we have the social mixing matrices, we have the age distribution, the population, and we're seeing that the impact in terms of incidence of disease, this is stratified by age group, in terms of symptomatic infection, and in terms of critical patients, is really very much different. So this is it's a work that is actually ongoing, and this is to evaluate the contribution of both the demographic structure and social interaction in order to kind of assess and project what possible trends and burden of disease we will see in the different contexts. So optimal vaccine allocation is another question we have been asking through the use of mathematical models. And here we have set up a meta-population SIR model, whereby the various countries are connected through air flight and ground transportation data. Under the perspective of the United States, we ask whether cooperative versus an uncooperative vaccine allocation strategies would have produced beneficial results in terms of avoiding number of cases. And we found out that for certain level of susceptibility in the US and in the foreign country, it is convenient for the US to donate additional doses of vaccine to other countries instead of distributing them internally. And this is the area in blue that you see in the plot. So for certain level of susceptibility, which also give us the level of how close we are to reach herd immunity thresholds, for certain level of susceptibility, it's actually more beneficial for the US to donate vaccine to third world countries rather than to keep these vaccine doses within the United States. So finally, we have all seen the importance of human behavior during the past year on the spread of infections. We have seen that the importance of physical or also non-physical interaction, the compliance to restrictive measure, and also the importance of emotions and fears, especially in the last few days, if I can say, and how much this can affect the global situation. And it is very, very important to take these aspects into account when we model and we use mathematical model to project and to foresee what is going to happen. So in this direction, we are in the process of analyzing some Twitter data. We have been collecting Twitter data from the beginning of last year. And this is just a snapshot of what we are seeing and the topics that have been discussed on the internet, on Twitter over time. And you see that the health topic is actually increasing slightly over the course of the year. And within the Twitter that are actually focusing on health, we are looking at the emotions of individuals that have posted those tweets, just by doing sentiment analysis and analyzing the content of these tweets. And these are aspects that are signals that are going to be used in order to kind of provide the other side of the coin. So on one hand, we have the offer from the side point of view, the offer of vaccines and vaccination doses to the community. On the other hand, we have to take into account also the response of the public and whether the events that are actually happening in our societies are kind of incentivizing individuals to comply to this measure, to accept these policies, or whether they are actually keeping them apart. So we are going to work more on this. So I take this opportunity to advertise that we will start, as Francesco Billari mentioned before, we are starting a new project here at Bocconi June this year. And this project is really looking at modeling the impact of human behaviors on infection spread. So taking into consideration all the aspects related to changes and changes in human behavior, changes in perception, changes in fears, how this might affect the spread of the infection. So embedding these two aspects within the same modeling framework. So take-home messages here, I'd say that mathematical models represent and have represented over the past year a very important and essential tool that we have used to study the evolution of a particular contagion process. However, when we talk about infectious disease, we have to remember that these are very, very complex processes that we are looking, and these processes embed several dimensions from epidemiology, demography, human behavior, mobility, and also the emotional components that have to be considered and taken into account in order to produce outcomes that are robust and that are useful for policy decision making. So I just like to close by thanking all the several peoples and several institutes that have been contributing to this work. It's not just me, there are lots of people that have done stuff about this. And I thank you all for listening. Thank you.
Thank you very much, Alessia. Thank you very much, Professor Melegaro. And indeed, we will stay tuned and follow closely your research. And I invite all interested public to follow Alessia's research. And now let me have the privilege to call Professor Karsai on stage. So Márton Karsai is Associate Professor at Central European University. In particular, he's at the Department of Network and Data Science. He's also a researcher at the Rennie Institute of Mathematics, and he's a fellow of the ISI Foundation in Turin. He's also a scientific advisor of UNICEF. So many roles for Professor Karsai, and today he will tell us about his research in monitoring behavioral responses during the COVID pandemic, and collecting data about online and offline behavior. So using many strategies to understand how we behave during the pandemic. Floor is yours, Márton. Welcome, Professor Karsai.
Thank you very much. I hope you can see my slides. First of all, I'm very excited to be invited to this lecture series and talking in front of so many people. As I heard, we are over 700 over here. And thank you for the kind introduction. Today I'm going to talk about data collection effort, what we carried out in Hungary in order to monitor how people change their behavior during the pandemic, using two data collection methods, one online and one offline. Let me to start my talk about one of the largest challenges we faced during the pandemic in terms of modeling, as already Professor Melegaro mentioned, is to follow the people, how people change their behavior. This change, actually, the epidemic itself is altering our behavior in many, many different ways. And most important from a modeling point of view is, of course, the change in our mobility patterns, how we move in space between cities, inside cities, between countries and continents, but also how our social interactions and social contexts change due to the external extreme events. A very good example I'm showing here is the Times Square. On a usual pre-COVID day, you see so many people moving around, being in proximity of each other, which actually radically changed once restrictions has been introduced in the US, in New York, and the same location, which was one of the crowdest places on the globe, completely emptied out. There could be several reasons why people change behavior radically, as demonstrated on these images. First of all, everyone thinks first on regulations and policies, which are put in place in order to stop an epidemic and prevent further spread of the disease in a larger population. But there are many other factors, like, for example, the fear from the disease, or people's recognition that they have to self-protect themselves, wearing masks or keeping distances. Also due to lack of trust in information, or policymakers or experts can change their behavior, could lead to believe in misinformation and alternative facts, which in turn can lead to controversial effects, like, for example, protest on site by crowds of people in the middle of a pandemic, which is very, very dangerous behavior. On the other hand, when we are observing behavioral changes, it's very difficult to isolate the single reason which is causing them. Usually, all these reasons are convoluted and inducing change in behavior in terms of social mobility patterns of people. But yet we can ask the question, why is it so important to follow behavioral change during the pandemic, for example? The reason why is because change of behavior is altering the outcome of the epidemic. If we change how we travel, or if we change how we interact with others, it is going to change how the infection is transmitted, or with what frequency is transmitted between people. Because of the pandemic like the COVID-19, or the epidemic like COVID-19 is transmitted between people by physical proximity, we can apply techniques, for example, provided by network science, describing mobility and social network structures, but they are all important in order to follow how people may reduce their social contacts or change their mobility patterns during pandemic. So it is very important, in one hand, just to see how it is changing the epidemic outcomes, so provide understanding about the epidemic. But it is also very important because behavioral changing patterns can be incorporated in epidemic models, and these models then can, if the data provides, online, on real time, adopt and change the predicted epidemic outcome based on people's movement, based on people's social mixing patterns, etc., etc. So, of course, there are different types of data one can collect to monitor behavioral changes. There are some data or some type of behavior that can easier be followed. For example, mobility and transportation patterns are typically they are easier to monitor. For example, on the left-hand side, you see how flights are flying over Europe on a typical day in 2019 in April, while on the right-hand side, you see a very similar day a year later in 2020, and you see the radical change in the number of flights over Europe due to restrictions and ban of international travel. This radical change is actually one reason why the first wave was actually reduced in Europe. On the other hand, you can also look for smaller scale mobility patterns, like on the top right, I show you the Apple mobility trends about Hungary over the last year, where you see that the fraction of people driving and walking switched over once there were some restrictions put in place in Hungary, and this is going up and down due to seasonal effects, but also because of restrictions, and they are particularly different than the baseline behavior on a usual day when there is no pandemic. The third source of data what we could use for such analysis or such monitoring is, of course, coming from mobile phones or wearable devices. On the bottom right figure, I show you mobility map we extracted from mobile phones in Hungary, showing that on a typical day, not during the pandemic, how people move between different settlements all around the country. So these are the, let's say, easy to follow behavioral metrics. On the other hand, there are several others which are important, but they are particularly difficult to follow. For example, it's very difficult to follow individual behavioral change, like how much time one spends inside or outside, how one's work conditions changing, health conditions changing, self-protection behavior is changing, or even the mental health. just going one level higher, one can also try to look how social behavior changes, which is very important, as I already explained, for the transmission of disease. Here the questions are, what is the average number of social contacts of people at a given day? How do they socially mix? How the quality of their social interactions changing, which is due to social distancing, but also because people wear masks and they cannot look at each other's faces. And even if you think about a larger picture, how the social structure is influenced by a lockdown or an epidemic situation, like how segregation patterns are changing due to the ability of different socioeconomic groups to adapt to a given situation. And finally, a third category of behavioral metrics, which are very important, as already Professor Melegaro mentioned, are the ones which are about the individual collective opinion. Here we can think about the acceptance or the denial of facts related to the virus, or attitudes towards regulating policies, lockdowns, trust in decisions, experts in information. In the beginning of 2020 March, when the epidemic hit Hungary, and we were trying to design models which were adapting to the actual situation, we realized that we didn't have any of this data. And on the other hand, they are crucial for a precise epidemic model. So we came up with the idea to set up a large-scale data collection infrastructure, let's call it like this, what we call MASK. This is the Hungarian data provider questionnaire. You can actually see it by yourself if you visit the link below. And through this infrastructure, we were aiming to reach out to many people to see how their behavior changing as a function of time over the several months of the pandemic. I have to say that we started a year ago on the 23rd of March, and this data collection effort became quite a success. First of all, because we were very careful to design that it is completely anonym, so people are not re-identifiable. They are not giving any personal information, which is allowing their identification from the dataset. It is completely voluntary. And we can think about this as a rolling data collection where we are asking about the behavior of people during the previous day or before the pandemic arrived to Hungary. So it is dynamical. We can have even daily resolution data about behavioral changes, and it is relatively cheap. The main goals of this whole effort were twofold. One, we tried to estimate age contact matrices, as you have already heard about, which is a very important element for epidemic modeling, because this describes how different age groups mix together, what is the probability that people from different age groups meet at a given day. But we also wanted to follow behavior and opinion changes by asking questions related to topics I already mentioned. So over the last year, we succeeded to reach over 230,000 respondents in Hungary, and we had over 442,000 responses. So just to put this in context, 230,000 respondents, this is more than 2.3% of the Hungarian population, which is quite large. We were even very surprised that so many people got engaged with our questionnaire. The questionnaire was designed such that it took in mainly three parts. One part was asking the general information of people which do not change, like demographic information, age, gender, or their location, their occupation, education, and other information about their health and their family structure. A second part was asking about their social patterns before the pandemic arrived to Hungary. That's what we call the reference period measures, so that we could see what was the number of social contacts, for example, a person had before the 23rd of March. And the second part of the questionnaire was asking about the previous day of the respondent, whether he or she was abroad in another city, and more importantly, whether he or she testing, got infected, what things he or she had done on the previous day. And finally, the core of the questionnaire was focusing on age contact matrices. However, before I define age contact matrices, I would like to define how we consider the social contact to be. We defined two types of social contacts. One was a proxy contact, so to speak, where we asked how many people a person spent within 2 meters for longer than 15 minutes on a given day, or physical contact, which was the number of contacts a person had a physical touch without protection. So asking a person how many proxy contact he or she had at a given situation, at home, at work, outside, inside, at school, with other people from different age groups, just simply filling in this radio button board, we could have these individual level answers aggregated into a matrix, which in turn could tell us what's the probability that a person from a given age group, like between 30 and 44, met on the previous day with another person from another age group, like between 70 and 79. Using this whole data set, we could actually monitor different types of behavior. The first and maybe the simplest one is to look at mobility patterns and see how people move between cities from the beginning of the study. And although our data was very sparse in that sense, because we have about 1,000 respondents per day, which is negligible compared to the Hungarian population, we could yet see some apparent behavioral pattern or change in behavioral patterns. Like if we compare the mobility map before lockdown and during lockdown, we could see that this mobility network collapsed. The long distance travels more or less disappeared from the system, and only local travels around the local hubs and larger cities, like for example Budapest, remained in the network. Further, we made some statistical analysis of our respondents, and we realized that our respondents are not all over the country and the population. First of all, we saw, as you see on the map on the left-hand side, that most of our respondents are coming from the western part of the country, while people from the eastern part of the country are less active in terms of answering our survey. But we could also look for different demographic dimensions like age, employment status, settlement type, where people are from, education or gender, and we found that actually our respondents are mostly middle-aged ladies with a university degrees living in a large city, which made us realize that, well, the data we collected is large, but despite its size, it is rather underrepresentative for the Hungarian population, which is a problem. In order to solve this major shortcoming, we came up with the idea that we should collect parallel another data set based on the same questionnaire, but using data collection which allows for representative sampling. So we turned to a survey company to collect a sample of 1,500 people per month, which were selected nationally in a national representative way from the Hungarian population. They were called up every month, different 1,500 people, and they were asked the same question. And using these two data, the one coming from online every day and the one but representative coming from the phone surveys every month, we could actually work out a statistical method that we could reweight based on the representative phone survey and the census data, the online data collection, that it became close to representative. And then we could actually exploit all the advantages of our cheap, dynamical online data collection. If we would like to monitor more important, another important metric of behavioral change, we could look at how the average number of social contacts change as a function of time. Here on the very left side of the figure, you see that during the reference period, so before the COVID-19 pandemic in Hungary, on average a person had about 26 proxy social interactions. When the pandemic arrived to Hungary in the end of March, middle of March, and the first regulations were put in place, this number reduced radically by 90% to the average number of 3. And this was remaining quite low until the first and the second release of the restrictions happened to the countryside and then later to the capital, which increased the average number of contacts yet a little bit higher. It actually has never reached the original very high number of 26 since the pandemic started. The other period when there was a a significant increase in the number of social ties was during the end of summer, when people came back from holidays and they went back to schools. And then after the second wave arrived to Hungary, and now the third wave, this number decreased radically. You can see on the figure, it is computed until day before yesterday. There is the strongest restriction applied in Hungary since about a week, with almost complete lockdown, and this reduced the average number of social ties under 2, which is even lower than during the first lockdown. Using the representative data, every month we could compute an age contact matrix, what I already defined, and using the combination of the online and the representative data, actually we could compute every day from the online data a social contact matrix, an age contact matrix, and see how it is changing as a function of time. Why is it so important? As Professor Melegaro explained, this is a very, very crucial input for epidemic models, because it is telling us in what way different social groups, or age groups in this case, are mixing together, meaning how the probability of transmission of disease between people from different age groups is changing. So computing these matrices dynamically with a daily resolution was very, very crucial for our modeling team, who we were actually providing this data as input. As another example of behavioral change, and maybe giving some insight about maybe causal relationships between behavioral change and the epidemic of the second wave, I would like to show you how people traveled abroad during our observation period. This is the yellow line on the top figure, where you see that while during the first period of the pandemic people stayed at home, in the end of July, beginning of August, which is the typical time when Hungarians go for holiday, all of a sudden there was a radical increase of people traveling abroad, which meant that they went abroad, they were meeting other people, they were mixing with others, and then when they came back to Hungary, to their original, to their home location, to their homes, they could actually bring the disease in the country and could spread it around. Then at the same time, once they came back, the number of contacts, because they went back to work and because school started, increased radically, as you see from the bottom figure. And that could be the reason that these two effects, people bringing back the virus from abroad, mixing locally and then increasing their social ties, could cause the radical increase in the second wave, which happened in the beginning or middle of October. We were also interested in how people change their self-protection behavior. So we monitored the fraction of mask usage. As you see on the blue curve on the plot, you see that in the beginning of the pandemic, people were not very fan of masks. Only the 40% of them were wearing them on the daily basis, while due to restrictions and regulations as well, since the second and especially since the third wave, this grew to 90%, which is a very important result. Finally, we could also look for important question about people's mind, like how much you think the following measures protect you from the COVID-19 virus. And by asking this very simple question and giving them the answers we got from the international literature, we found very, very strange and frightening results, suggesting that actually 41% of people think that eating fruits and vegetables or cleaning their home will protect completely them from the COVID-19 virus, or positive thinking and reducing stress will completely protect them from the virus. 30% or 26% of people think this way. Further, we had several other questions about individuals' opinion. What do they think about conteos or conspiracy theories, their attitudes towards vaccination, their trust in decision makers and experts, their fears, or even in which channels they are actually obtaining information about the virus. But I'm not going to talk about these results due to the lack of time. So finally, I would like to conclude that we set up monitoring system, individual behavior monitoring system, which is completely anonymous. It is close to representative, and the participation is voluntary. And it is very crucial to provide real-time data for real-time modeling of epidemic processes. But on the top, it is also allowing to monitor public opinion, to give insights for policymakers about the expected, about the reflection of people on the different restrictions, and to explain how they change their behavior. If you're interested in this research, we already have 2 papers out. And finally, I would like to thank my data analytics team who worked on this project as a part of the Hungarian COVID force team actually advising the cabinet of the Hungarian government. Thank you very much.
Thank you very much, Márton. Thank you, Professor Karsai. We see that researchers have been at the forefront also of supporting government responses against the pandemic. So this is a crucial applied and policy relevant work that has been done. Let me then move to the next speaker. I'm very pleased to introduce Professor David Levine. He's professor of microeconomics. He holds a joint chair between economics and the Robert Schuman Center for Advanced Studies at the European University Institute. He's also an emeritus distinguished professor of economics at the Washington University in St. Louis. He will guide us in thinking about the role of social science and social science data in the COVID-19 pandemic. The floor is yours, David.
Okay, you just heard from 2 researchers who are on the front lines of doing social science research on COVID-19. I'm going to step back and give a somewhat broader view. Part of the reason for that is, unlike the previous speakers, I'm not somebody who is currently doing active research with data on COVID-19. I'm actually an economic theorist. I don't do empirical work myself, although many of my students do. So I've been involved much more in the organization, the promotion of research, as opposed to actually doing research. This gives me a much shallower view of the research than people such as Alessia and Márton, who are actually actively doing the research, but in many ways it also gives me a broader view of what's going on. I want to try to share some of that broader view and connect it to some of the things that the previous 2 speakers said. I've been involved in setting up a research conduit for social scientists to try to get social scientists more engaged with policymakers and better access to data. And I want to say something about whether that's worked. A short messages, not very well. I'm now coordinating efforts to build a longer-term institution that would give social scientists better access to data and better connections to the public and policymakers. I'm going to start with a picture. It's about data. Let's talk about data. This is some data. This is a picture from the Financial Times. This is about on the horizontal axis of this diagram, as you move to the right, more people are dying per million. As you move up in the diagram, the economy is doing better. And what you see in this diagram is that it's not the case that you need to have a lot of people die in order to have your economy do well. The Asian experience, particularly the East Asian experience, has been very, very different than the Western experience. These are the red dots up here. Vietnam, China, Taiwan is there, but I suppose for political reasons, there's not allowed to reproduce this up here somewhere too. South Korea, Indonesia, Japan. These countries all have relatively very low death rates. Actually, they have not had really serious outbreak in terms of deaths. They've had relatively little negative economic impact on their economies. If we go down to the lower right corner, we see countries that have really horrific numbers of deaths and also rather negative economic impact. UK and Spain, at the time of this, were the leaders. I'm afraid we here in Italy, perhaps we're not doing so much better than all that. And what I want to take away from this, first of all, is that there's something very different about this pandemic and previous pandemics. So previous pandemics never were as widespread, never had the huge economic social harm that this one has had. That is, we've had Ebola outbreaks, SARS, MERS, flus. We've had lots of different outbreaks of disease that have been widespread, but none of them have had this enormous impact. The number of people who've died has been much smaller. The impact on the economy has been much smaller. And that means in some sense that these events were more technical from the perspective of policy. The issue, there was no issue of urgent, what would be the impact of restrictions on our economy? This was not an issue in earlier outbreaks. It was really a technical issue for doctors, how best to treat the disease. Can people be vaccinated against the disease? What kind of isolation is desirable? What kind of treatment, and so forth and so on. Now, one consequence of this is that governments are in the habit of consulting with the medical profession and medical researchers about the best way to respond to a disease. Unfortunately, in the current pandemic, there's a variety of issues about appropriate and effective responses, which are ones for which medical researchers have little or no expertise at all. And this has led to some very, very bad advice and some very, very poor outcomes. Well, how bad and how poor? Contrast what happened in these countries in the upper left-hand corner with what happened in these countries down in the lower right-hand corner. This is not some sort of hypothetical thing. We unfortunately been confronted with the reality of countries with very, very different experiences. Okay, so now I want to say something about that. Here are some key issues. These are things that social scientists know about. Medical researchers do not know a great deal about these things. Question number one. Medical research say impose restrictions. People should stay home. They should wear masks. Government put that into effect. They say people should stay home. People should wear masks. People should not show up in stores. Fine. But doesn't make any difference unless people follow those restrictions. So you saw some of that in Márton's talk, right? He talked about, for example, actual mask usage. It was never 100%. In early days, it was much less than that. So that's question number. That's a picture, by the way, of Dominic Cummings, the famous British guy who violated all the restrictions that he had personally been responsible for putting in effect. So people can, and they do cheat on restrictions, and the amount of cheating may be very different depending upon social organization of different countries, incentives, work habits, and all these different things you heard Márton and you heard Alessia talking about when they're talking about behavior and they're talking about data. Now, another question that goes the other way. To what extent will people restrict themselves in the absence of legal government restrictions? So Sweden actually didn't do terribly well, didn't do terribly poorly. It's somewhere in the middle. Sweden is right here. Very little economic harm and serious outbreak, but certainly nothing like some of the worst countries there. So, but they didn't put in legal restrictions until very late. Now, why is it that that worked in Sweden? Maybe that wouldn't have worked in Italy. Why might that be? Because maybe if the government makes recommendations in Sweden, even though they're not laws, people follow them. And perhaps in Italy, if the government make recommendations, nobody pays any attention to it. And unless they're laws, people don't do it. So there's this issue of what extent do restrictions that are imposed by government have an effect? And to what extent will people restrict them even in the absence of government recommendations or government laws? Now, there's other social science issues that are important as well. Political issues. So in the United States, there's a huge fight going on between parents and teachers. Parents who want to get their kids back in school and teachers who are afraid to go to school to teach. Okay. Here you have a very strong contrast. There's been enormous political upheaval over this. The two political parties in the United States are at war over this. Here is another issue that comes about because different groups of people have different gains and different losses from changing of restrictions, such as the opening of schools. Okay. It was already earlier mentioned, protests. So one of the things that people do if they're bored and they're locked at home and they don't have jobs and they're not allowed to go to school is they get upset about things. Maybe they get upset about restrictions, or maybe they just get upset about black people being killed. But whatever they get upset about, they go out and they protest. Here's a picture, right? And in doing so, of course, they spread the disease further. So there's absolutely no sense in trying to lock people in their houses if the consequence is that is going to be they're all going to go out of their houses, go into the street and protest and spread the disease even more than if they were allowed to lead normal lives. Okay. All of these are issues that are studied by social scientists and to many extent understood by social scientists and for which medical research had very little knowledge or experience. Let's talk about vaccines in this context. Medical safety agencies do not properly, this is well known among health researchers and economists, do not properly weigh the consequences of non-treatment. And as a result, they cannot really be trusted to operate on their own in the face of a pandemic. What do I mean by weigh the consequences of non-treatment? Medical safety agencies talk about the fact that a particular medical treatment, a vaccine or a medicine, may have risk involved with it and may cause adverse consequences. They properly look at that. But of course, if you don't use the medicine and you don't treat people, that has consequences too. And in this case, the consequence is people get sick and they die. Okay, so we've seen some very strange stuff going on. So in Italy, for example, they've vaccinated more in the 20 to 29-year-old age group, even though that age group faces virtually no risk from the disease whatsoever. They've vaccinated more people between 20 and 29 years old than between 60 and 69 years old, even though the 60 to 69-year-olds actually need the vaccination for their safety and the 20 to 29-year-olds do not. Why is that? Because there was all this silliness about the AstraZeneca vaccine. It's not safe for people over 55. All right, now it really is safe for people over 55, but not over 65. Oh, actually, it's safe for everybody. And then, of course, there's been the recent issue of whether or not it causes blood clots. So there's this issue. Who should be vaccinated first? What is most effective? That depends on a lot of the elements and the models that are being described in the previous lecture. That is, who's spreading the disease? What do the social contacts look like? Who has to go to work? Who can stay at home? Who wants to stay at home? These are things you need to know about in order to understand who should be vaccinated first. There's also a legal issue for lawyers who are also social scientists in many cases. Do governments have the right to deny vaccination or treatment to citizens based on their own belief that the treatment is insufficiently proven? That is, if I, as a government official, think it's dangerous, do I get to tell people that they can't take that treatment? There's a real issue there as well. Now, two places that follow the advice, the science, in quotes here, the advice of medical advisors were the EU and Canada. What happened with vaccinations in those countries? Here's the vaccinations as of March 12th as a percentage of the population. Israel, as you know, is over 100% by now. The UK is up to about 30%. Chile, the United States, very similar numbers. Here we go. Spain, Poland, Switzerland, Denmark, 10%-ish. Italy, 10%-ish. Germany, 10%-ish. Canada's even worse, 7.5%. These countries took their time about proving the vaccine, have issued the vaccine in stops and starts, did not invest in production capacity for the vaccines, and as a result, they don't really have very many vaccines and haven't vaccinated very many people. Now, I want to come to something that's been in the news today, even, in fact, in the news even at the start of this talk. So I want to look at data. This is about data, and this is about the analysis of data. So I want to look at some data, and I want to analyze some data. Okay, and I want to indicate that there's an issue here with the lack of transparency, because some of the numbers that I'm using here, I had to scrape out of newspaper articles. The only thing that I used below that was easy to find were the death rates. But as it turns out, it doesn't matter very much. So here is my source of information about the cardiovascular risk from the AstraZeneca vaccine. That comes from Sky News, of all places. Why? Because as a social scientist, I can't get anything else. So the figures that they give are 6 million thromboembolic events, blood clots. Possibly one of them resulted in a death out of a million vaccinations that were given. That, by the way, is a lifetime risk, and it's important to understand the time frame of risk. That is, you get a shot, well, could be twice in a lifetime risk because you get 2 shots, although probably if you survive blood clots the first time, you're not going to get a blood clot the second time. But you do this once or twice in your lifetime, and that's it. Now, let's suppose that all of those 6 million people died, okay? Out of 1 million people. So you give 6 million, you give 1 million people shots. Let's suppose 6 of them die. Let's suppose, almost certainly this isn't true. Basically, all these people would have died anyway because the blood clots had nothing to do with the vaccine, but doesn't matter. We can do worst case analysis. We can do this very simply and very easily and say, what happens even if it were true that we were killing 6 million people with blood clots out of every million doses of vaccine that were given. So there's another element, of course, of vaccination, and that's the benefit. So the AstraZeneca vaccine also makes you less likely to die. It reduces the possibility of getting severe illness from COVID-19 by about 80%. Pfizer's about the same. We don't actually know what the death saving is for AstraZeneca because there's apparently not enough data, but we can think it's about the same. Actually, as far as we know, nobody has died from COVID-19 3 weeks after getting the AstraZeneca vaccine. But at any rate, we can assume a number around there. Okay, now, in order to understand whether it's a good idea to get the vaccine or not, you need to know what risk you're taking. If you're planning to spend the rest of your life inside your house and never see another human being again, then you don't face any risk of getting COVID-19, and it would be silly to get a vaccine that would have some risk involved with it. On the other hand, most people don't do that. And so we know how many people are dying because they didn't stay in their houses. These are 2-week death rates. This is the one number you can actually find in a reliable way. Norway and Denmark, which were the first countries to put a pause on the AstraZeneca vaccine, that number is about 5 people per million over 2 weeks dying of COVID-19. In Ireland, about 50, Netherlands, about 30, also in Italy, about, I think it's 50, in Germany, it's about 40. Except for Norway and Denmark, all these numbers are pretty high. So what does that mean? It means if you give 1 million shots of AstraZeneca vaccine over 2 weeks, the number of lives that you will save is about 4 in Norway and Denmark, about 37 in Ireland, and about 22 in the Netherlands. Now, if you could give them, say, Pfizer vaccine instead, of course, maybe that would be a good idea. You pause AstraZeneca and give them Pfizer. But you cannot do that because all of the Pfizer vaccines are being used. It's AstraZeneca or it's nothing, okay? So we're talking about what? We're talking about possibly saving 30 or 40 million people. At worst possible case, so 30 or 40 people saved versus in an extremely unlikely set of circumstances, killing 6. And that's the number 30 or 40 is over 2 weeks. So that means if you delay this vaccination by 2 weeks, what have you done? You've saved nobody, okay, from the thromboembolic events, because you're going to go right back to giving them the vaccine in 2 weeks' time anyway. No, all you did was to kill out of 1 million people, out of 1 million vaccines you could have given 40 people. That's all you did. That's the only accomplishment. By the way, I want to give some context for these numbers. How big is the risk of 6 per million? How big is the risk of 37 per million? If you go to Brazil for 1 year, it raises your chance of being murdered by a number that's about 30 in 1 million. Now, some people would not care to go to Brazil for fear of being murdered, but many people would go to Brazil. So these are not risks that are somehow, we can't understand these numbers. They're too big or too small or too insane, okay? Now, so what actually happened, I should say, it was just announced, just as this seminar started, that the European Medical Agency reached the same conclusion today that they did yesterday, the day before on Monday, which is that AstraZeneca vaccine is indeed, it's safe, it's effective, it's a good vaccine. They studied it again. They reached the same conclusion they reached before. So that what these countries have done, Germany, France, Italy, Spain, all they have done is to avoid vaccinating people for 1 week. And some of those people are going to die. This is the use of data. This is the use of social science data. This is why we need social science researchers looking at these numbers. Okay, let's come to the social science questions. These have been raised in some of the earlier talks. One of the issues here is what's called endogenative behavior. People respond to their incentives and their circumstances. So I already spoke about cheating versus self-restricting. Businesses would like to be open, but we have to ask the question, when there's a huge outbreak, even if we allowed businesses to be open, would anybody go? Of course, many people wouldn't. We need to ask questions about whether restrictions are legal. For example, they imposed a curfew in the Netherlands. A court said that you're not allowed to do that, okay? Ultimately, all of these issues are not theoretical issues. Theory can guide us, but it cannot answer these questions. They are empirical issues. And the critical element is access to data so we can tell what is happening and we can predict what will happen. Okay? We have faced as social scientists very important data challenges and organizational challenges. Our voices are not much listened to at the level of policymakers. We have very limited access to data. This was true at the beginning of the pandemic. I'm sorry to say it has not improved a great deal over the course of the pandemic. I mean, we see here very silly things that were done at the beginning of the pandemic. We're seeing now here very silly things being done in the vaccination campaign. We see voices that know better not being consulted. Okay, I'm going to talk specifically about some of the data challenges as social scientists. I'm going to talk first about information that comes from my colleague, Andre Aquino, who actively does research in this area. So one of the important issues is we'd like to understand what the impact on education is of distance learning that's been introduced as an alternative to in-person learning that takes place, has taken place during these close downs. Google provides a lot of free distance learning software in Italy. As a result, they collect a lot of data about distance learning. That is data that would be very valuable to a researcher studying this. But here's the question. Google is a huge organization. How does a researcher or graduate student go about trying to get this data from Google? There's not a WHO that you can turn to, right? There's not a place you can go and say, look, could you make contact with Google for me? Okay. We talked earlier about risk data and about contact data. It's essential in studying these models to understand how risk varies by age, by occupation, and by a variety of other criteria. Aquino and his co-authors were able to get data from the Bank of Italy directed at this. But again, this is all very hit and miss affair. There's this bit of data there. There's that bit of data here. Every single researcher has to go out and try to acquire data on their own. It's crucial data. It can be hard to come by. And of course, it's difficult to know what data is available and it's not available. Let me talk about some research that I helped to instigate, even though I didn't participate in it. This is also very similar to the data that Márton described for Hungary. Gathering, this is not, he talked about data that was gathered on an ongoing basis. This is a one-time survey that looked at many of the same sets of issues for the same reasons. This used representative samples as they did in one of their studies in Hungary. However, this was conducted across 6 different countries, and that's important to understand why are South Korea and China and Japan doing better than Italy, the UK, and the 4 states in the United States. Okay, so they gathered data from a random sample of people in these countries about work and living conditions, about income, about behavior, beliefs about the COVID pandemic, exposure to the virus, socio-demographic characteristics, and pre-pandemic health characteristics. What they did not get data about is infection status. There's an obvious reason for that. Too few people are infected in a random sample. This is a survey that needs to be given to people that are going to hospitals and being diagnosed with COVID-19 so we can understand how people that are infected differ from people that aren't infected. This was not being done. This is not being done. We have repeatedly tried to get medical authorities to cooperate in this. They do not do so. So there's a real lack of cooperation on the medical side with social scientists. Okay, let's talk about endogenous adaptation a little bit more specifically. I'll talk specifically about work done by Alessia Musillo, Paolo Pin, and Tiziana Razzolini. They study the adjustment of how people's trade networks change in response to infection rates. And what they discover is that people changing their behavior to protect themselves can actually increase the extent of effectiveness of a disease. Exactly the opposite of what you'd hope for. People trying to protect themselves actually make things worse. And they have data, not on COVID-19, but from other pandemics and other epidemics, in which they discover that indeed this has happened, that people trying to adjust to protect themselves individually have made a bad situation even worse. This is why we need to understand these things. This is why we need the data in order to see what is happening. Okay, I'm going to wrap up just with a word about the Organization of Social Scientists. We don't have a WHO. I don't know if the WHO is still creditable. It's an interesting experience in Czechia. There, the Institute Serge EI was a credible institute listened to by the government. They were listening to the government early in the pandemic. As a result, Czechia had a very good early experience with the pandemic. Unfortunately, once they thought they had it beaten, they stopped listening to the social scientists and the medical people, the organization, and they said, great, we solved the problem, let's go back to life as normal, and now they have one of the worst outbreaks anywhere in the world. It's also the case that health in general has not been central in the social sciences. So my student, Nicholas Papageorge, my colleague, Elin von Brock-Altenberg, these are people who in the past, being health economists, have been pushed to the periphery of the profession. I'm glad to say that that has changed a great deal. I'm an editor of the European Economic Review. We now have a special section on COVID-19, and we get about 5 manuscripts a week by economists, just this one journal, on this particular topic. So I think the importance is recognized, work is going on. We need to make better access to data and have credible institutions for communicating with policymakers. I just want to conclude by saying that at the EUI, we're working on such a project to build such an invitation, and I will stop there. I don't know where I am on time, but I heard some grumbling in the background.
Thank you very much, David. Thanks, Professor Levine. Let me call on stage now all the 3 speakers. We've heard fantastic perspectives, interesting results, and also critical remarks by David. And I would like to challenge the speakers on a couple of issues that spring to my mind in general. And here I'm focusing on the role of social science. I mean, being CIVICA, an alliance of social science universities, we like to shape the social sciences. As David pointed out, we like to also showcase the importance of social science for doing research in general about the world, and also for collecting data. And also Márton and Alessia showed us how to actually do this research. So my question is, COVID-19 will go away, hopefully, soon. It's been a year now. How do you think social science will change after COVID-19? What will be changed forever? What's your feeling? Let me go in a reverse order here. Let me ask David first, and then I'll go to Márton and Alessia. How do you think this shock will be permanent, David?
So I don't think I'm an economist. Let me speak to the economics part of it and not to the social sciences more broadly, because I would have less to say perhaps about that impact. Within economics, I don't think it will change the science itself, but it has raised awareness of health economics and pandemic economics. I'm sure that the 5 papers a week that we're getting will get to be a much smaller number a year's time from now. But I think that this, as a subdiscipline with economics, has achieved an importance and recognition that was not present before, and I don't expect that to go away. I expect that health economics is have a much more central role in economics than has ever been the case in the past, going on into the indefinite future.
Thanks. Márton.
In my opinion, what I see as a quantitative scientist, that this is very unprecedented situation when social sciences and hard sciences mix together for a larger purpose. And I think this connection remain, or I hope this connection is going to remain. And also I see it as a opportunity, let's say it like this, although it's a very unfortunate opportunity, to use all the data collected about this situation as a natural experimental setting, where people, social scientists, can study on scale and detail phenomena, but they could just, theorize and hypothesize earlier.
Thanks. Alessia.
I think this, the past year has been an emergency here, and so many things have been done not in the most efficient, effective, and optimal way. But still, I want to be optimistic in the sense that I think this year gave us the opportunity to create bridges between different disciplines. And I think there were some bridges that were kind of on hold in the past, and some bridges that were and are required in order to address these issues in a more kind of effective way. So I think, of course, during the emergency, these bridges have to be built in the kind of a quickest possible way, and so there are downturns and things that are not going in the best possible way. But still, I think I hope that for kind of when the COVID will be gone, this will have open up possibilities of collaborations. And I think, I mean, epidemiology is a discipline that has a long history and a long kind of a very kind of a lot of interdisciplinary research is going on in some countries, has been going on in some countries, in other countries less so. And so I'm really hoping that, and it is a requirement for really understanding this population phenomena. So I really hope that maintaining the kind of a specific and the expertise of the different disciplines separate in a sense, but collaborations and contributions will be easier in the future.
Could I add something to that?
Please.
I would like to reinforce that and also indicate I don't think this is such a temporary thing. So it's certainly the case that within the era of COVID-19, economists have been collaborating with people from other disciplines, political scientists, but also medical people, epidemiologists, and people with expertise in other areas. This has traditionally not been so common for economists. But I'll point to the experience of economists who are studying climate change. Economists who study climate change almost always do interdisciplinary work now. You have to, because if the economists just don't have any expertise in the mechanics of climate change. We don't know what the carbon cycle is. We have to get that from scientists. And you have to work with scientists who know these things in order to do it. The same thing is true of COVID-19. I'm critical of medical researchers, not broadly. I think maybe I came across a little wrongly on that, but rather more narrowly, those who do not work across disciplines. We're very dependent, economists and social scientists, upon medical researchers. If we don't have people that understand about viruses and the transmissions of viruses, we're nowhere, right? And of course, we need to work with people like that. And my sense is after this crisis dies down, this kind of interdisciplinary research is not going to go away, because in order to do proper research in this area, you need combined information. Nobody's an expert both in viruses and viral transmission, and an expert in whether or not mask laws cause people to wear masks or not. There's just nobody that has expertise in both of those things, and so you need collaboration between both kinds of people. So I would like to very much second what Alessia has just said, and I would also like to say I do see that this is likely to continue into the future as well, for good reason.
So the prediction is that there will be also fewer barriers within the social sciences and between different social sciences and other disciplines, and maybe more research published on what one will define as general interest scientific journals, and not only kind of disciplinary journals. Maybe that will stay. Maybe that will stay also because these journals have developed. Let me move, and now I call Alessia first, or maybe Márton first. Let's move. Let's kind of the order, reshuffle. One of the challenges we have is not only data accessibility, but also the fact that if we have to study the world using data or to intervene on the world with data evidence, there is a bit of selectivity. We have data for the rich countries. That's been forever for social sciences. It's also becoming important for COVID-19. We have data for societies in which we have research funding, we have active researchers, whereas there is maybe no data or worse data for societies that don't have a good budget. Also within Europe, there is a huge heterogeneity in data availability, data accessibility. So there is inequality in data. How do we address that? Does this matter? Does it matter? Can we answer general questions on the world using Hungarian data, or do we need data from several contexts?
This is a very important question, in my opinion, because as you mentioned, the inequality in terms of data access is very, very crucial for many reasons. We are looking at the place right now where we can look at. So we look at countries where data has been collected, and this is usually the Western countries or more developed countries. But we forget about that the COVID-19 disease, for example, but many other crises hit other parts of the world even worse, where we don't have data. And I think the best example for this was the Ebola crisis, where the interventions were belated exactly because data was not available about the given territory. So this is very crucial in case of emergencies, but it is also very crucial if you would like to see, for example, how poverty or socioeconomic inequalities are structured in countries where you don't have data about. And in that sense, there are certain advances, like remote sensing technologies provide a lot of solutions using satellite or aerial imagery, or even UNICEF has several, as I heard, several technologies that they provide to collect even local medical data about territories where you cannot really, collect by yourself. So there is a move. There is a move on the international organization level. There is certainly move on the science and academic level, and hopefully there is going to be a larger move from the private sector as well, and then it can merge into larger data repositories, which is available for addressing important questions like that.
Thank you, Márton. Alessia.
Yeah, I'm quite aligned actually with what Márton said. I think an important role should be played by international organizations in setting up some standard and the kind of policies for data sharing in the benefit of the countries, not just to steal the data out of the country, but in the benefit of the countries. Especially when we talk about infectious diseases, we have learned this year that it's a global phenomenon. We cannot really constrain and focus just on one area because it's going to spread around. And so we need a lot of coordination between the countries and a lot of willingness to share what is available. I have to say that I've been seeing quite a lot of this over the past year, in the sense that even collaborations with developing countries, I have the feeling that people are kind of willing to share more, and it's becoming really important to have open access repository, open access publication, in the light of really giving the opportunity to researchers from all over the world to step in, support with the help and with the in collaboration and in active working with local teams. So I think, it's a long process, and probably, we have been seeing that data is always difficult to get, and this has been like that for developed countries as well over the past year. So this is a global point that you're making. But I think the process has started. There are some signals of willingness to share the data and the importance of data sharing in order to really support policies and being more effective. So that's my view.
Thanks, Alessia. David, you mentioned this issue during your talk. Do you think that's going to change, or how are we going to change this?
So part of the issue here is in this issue of accessibility, and also the nature of social science. We tend to be very insular in our research in some ways. That means it's a bit of a free-for-all when it comes to getting data. So I have students and colleagues that do field work before the pandemic, did field work in Africa, in India, in Latin America, gathering data, survey data, sometimes experimental data. So it's not that we cannot get data from these areas. Of course, that data often needs to be combined with other data, for example, government data. I have a student who's been negotiating with the country of Colombia in South America, trying to get data from Colombia. So part of the difficulty is that this is every individual researcher that wants to do this research identifies, okay, I need to do this field work. I need to get that government data, right? And what we need, this is a public good, right? Everybody needs to have access to all this data, right? It's crazy that each individual research has to go negotiate. In the case of the Columbia data, 2 previous researchers had to do the same negotiation in order to get their subset or different, slightly the same data, right? This is madness, right? It just obstructs research. It obstructs research on health and everything else, okay? So I don't know that the issue is, so record collection is particularly bad in other countries. It's not the case as far as I can tell. It's very difficult to get access to it, okay? But Nigeria has very good records, okay? Not easy to get them, but they exist. Colombia has very good records, but again, it's not easy to get access to them. So I don't think the issue is so much, and when it comes to this type of survey data that Márton is talking about, he goes out and he collects the data. We could go out and collect the data in Nigeria or Colombia. I have students that have done these sorts of things, right? Okay, the problem as I see it is that we're just so decentralized in the social sciences, right? That there's just all these different efforts going in this direction, that direction. I tried very hard when I was on a National Science Foundation panel several decades ago to try to get sort of better data in the aggregate sense, as opposed to all these little piecemeal bits of data that we get. So I see a lot of the problem lying in the piecemeal aspect of the data acquisition process.
Thank you, David. We'll probably continue forever if we had the time. This has been a terrific ride, but our time is over, and I'd like to thank our distinguished speakers for illuminating ideas and stimulating talks. And stay tuned for CIVICA activities. We'll be here for long. Thanks a lot.
Thank you for having us.
Thank you very much.
Thanks.